Okay, sorry. I got a little sidetracked there. I've have to start over 3 times, so I'm a little bit discombobulated. So, finishing off the endocrine um, PowerPoint, and so thyroid disease. Primarily, we have two issues: hypo or hyperthyroid. With hypo, then the thyroid gland, for whatever reason, is not producing enough T3 and T4, and in hyper, it's producing too much T3, T4. Well, why is that a problem? Well, the T3 and T4 regulate general body metabolism. It regulates metabolism of carbohydrates, protein, lipids, the things that we eat. Regulates our body temperature, helps to regulate our cardiovascular system, growth and maturation, lactation, and reproduction. So obviously, if we don't have enough or we have too much, these things are going to be affected. Now, sometimes it can simply be that there's a lack of iodine in the diet. Iodine is essential to the adequate functioning of the thyroid gland. And anyway, so let's see. Treatment, the goal is to return the thyroid, or return the body to a normal or euthyroid state, so that we have a balance again, so that the body isn't in high gear and it isn't in low gear. Primarily, we have two classes of drugs: thyroid replacement hormones that we would use for hypothyroidism, and antithyroid or thyroid destroying or blocking drugs that would be used to treat hyperthyroid. So thyroid replacement drugs obviously do just what they say. They're going to replace the missing T3 and T4 so that the patient begins to have more appropriate metabolism. So if you think about what the thyroid does, if the patient has not had enough thyroid medication or thyroid production, then they haven't had adequate metabolism. So think of all the systems that it affects. So if we don't have general body metabolism, how would we see that? Well, we're going to experience cold because our body's not producing any heat. We're going to experience weight gain because we're not burning any calories to produce heat. We're going to experience bradycardia because the heart's not being stimulated. So typically those are some of the hallmark signs of hypothyroid. Intolerance of cold temperatures, weight gain despite dieting perhaps, bradycardia, lack of energy. Those are some of the main things. Levothyroxine is the most commonly used medication for thyroid replacement. Synthroid is the trade name that you most commonly see. It's a synthetic T4, so it should stimulate metabolic activity. So once the patient begins to, and it could take several weeks for the patient to start to notice a difference, but they should start to see that as their body returns to this normal thyroid state, that they have better temperature tolerance. They may even lose a little bit of weight without having to work at it. Heart rate should return to normal. They should start to feel less lethargic, less sluggish, have more energy. So those are some of the main things that we would look at. Thyroid replacement, or levothyroxine, requires is another drug that has a narrow therapeutic margin, so they have to have monthly blood draws once they're stabilized to make sure that it's working. And we also want to make sure that patients know the symptoms that they should be looking for. So, if they start to experience the symptoms of hypothyroid, they need to call their provider, and if they start to experience the symptoms of hyperthyroid, they need to call. The primary symptoms of an adverse effect typically are related to dosage, and so a too high of a dose is going to give us the symptoms of hyperthyroid. So the patient's going to experience tachycardia, possibly with palpitations, anxiety, heat intolerance, significant weight loss. Those are the things that we would be, they might experience insomnia. So they need to be aware of those things. And if they start to experience that, now they also have to keep in mind that they may feel like those things are happening at a therapeutic dose because they're so used to being everything being slow, and being tired all the time, that the fact that they're not sleeping 20 hours a day might make them feel like, oh, I have insomnia. There's a lot of patient education to do. They need to know that this is a lifelong treatment. The thyroid isn't likely to just kick in and start producing thyroid hormone again. They need to know that it's best taken in the morning on an empty stomach. Now, why do you think we're going to take it in the morning? The primary reason is that it stimulates metabolism. So when do we want the patient to be alert and energetic? Is during the day when they're awake. The replacement hormones can impact blood glucose as we start to utilize, break down the foods better. The thyroid stimulates the liver to release the glucagon, so blood sugars rise. So your diabetic patients will need adjustment in their oral hypoglycemics or their insulin requirements. Now there's a couple of different antithyroid medications. We have iodine 131, which is a radioactive iodine that selectively destroys hyperactive thyroid tissue. It's used primarily for patients who aren't candidates for more aggressive treatments, such as thyroid surgery, thyroidectomy. So iodine 131 is a radioactive isotope of iodine. Now the thyroid gland utilizes iodine to do its job, so it's very sensitive to taking in iodine. So it takes in this iodine that's radioactive, and then that radioactivity is going to destroy that tissue because of the concentration of the radioactivity in the thyroid gland. Patients need to know that it can take 3 to 6 months to see benefit. And what benefit would we want them to see? Well, we want them to see that we're giving it because they're in a hyperthyroid state, so they're experiencing extreme tachycardia with possible palpitations, heat intolerance. They just feel kind of like they've had too much coffee, too much Red Bull, or full throttle. They're they're just kind of buzzy, energy without direction, perhaps. They may experience some tenderness in the thyroid gland, not really pain, but kind of like it feels bruised. Most likely, they will experience hypothyroidism, depending on how much thyroid tissue is destroyed. And yet they need to be aware that the thyroid tissue isn't going to be destroyed completely, and so therefore over time that thyroid overgrows again and the symptoms of hyperthyroidism may occur. They may even experience so much hypothyroidism that now they have to be on thyroid replacement hormones. Now, it is a radioactive substance, and during administration, care needs to be taken by the nurse to wear gloves, have supplies available in case of a spill, make sure that patients or people who are allergic to iodine don't come into contact with it. The patient, however, is not radioactive. Their urine and feces need to be, just take care with urine and feces, like they should be taught to double flush, but they, as a general rule, don't need to be isolated from others. Propylthiouracil, or PTU, and methimazole are different from radioactive iodine in that they don't destroy the tissue. They simply keep the thyroid tissue from making the T3, T4. Typically it's used for long-term maintenance of hyperthyroid or for presurgical treatment, because we want to keep that thyroid from making the thyroid hormone prior to surgery. The reason being that once the thyroid is manipulated during surgery, it will frequently send out a surge of thyroid hormones, and that of course is going to cause the patient all kinds of problems. Keep in mind that the PTU and the methimazole don't destroy tissue, don't destroy the T3 and T4 that's already in circulation. So it can take up to 3 weeks for the patient to see improvement in symptoms, depending on how much is circulating. So that has to be used up and destroyed by the body before they start to see symptom improvement. They may experience a rash that usually will resolve on its own, headache that again will resolve on its own, nephrotoxicity, hepatotoxicity, bone marrow suppression. These are things that we want to be aware of. So what are the symptoms of nephrotoxicity, hepatotoxicity? What would you expect symptoms of bone marrow suppression to be? These are the things that you're going to want to be teaching your patient what to look for that might indicate adverse effects. Now, corticosteroids are released by the adrenal glands. There are 2 types of hormones, two types of corticosteroids that the adrenals release. We have mineral corticoids and glucocorticoids, and they each have a different function. One of the biggest things about steroids is that they do have an impact on electrolyte balance, and especially the glucocorticoids, the mineral corticoids especially are going to impact electrolyte imbalance. The glucocorticoids are the ones that we primarily are giving when we're giving something for inflammation. So remember, they are immunosuppressant, and so we need to observe carefully for signs of infection. We may not have the usual high-grade fever. We're not going to have the signs of redness, drainage at a wound site, because those things are being suppressed by the glucocorticoid. So we may have to look for more generalized signs. A persistent low-grade fever, just general malaise when the patient says, I'm tired, I just don't feel good, though there's nothing they can pinpoint. Maybe a sore throat with no indication of other problems. If we need to know, it can alter their level of consciousness, so we need to get a baseline for that. Steroids can cause ulcers, so we need to know if they have a previous history, and GI bleed can be a concern. And then what's not listed here is that, again, especially glucocorticoids can raise the blood sugar. And so frequently we will be monitoring a patient's blood sugar, whether or not they're a diabetic, when they're on a glucocorticoid. Maybe I got them out of order. We'll see. Or else I skipped something and I'll have to come back to it. Steroids typically will have an interaction with diuretics, because steroids can enhance the loss of potassium. So if we're using a loop diuretic, a thiazide diuretic, and they're on steroids, then we need to be monitoring that potassium. And we're going to see this more, obviously, with the mineral corticoid, fluticasone, because of the sodium. Sodium then is going to be an issue, because we're giving one medication to retain sodium and then another medication to get rid of sodium. So typically we're not going to use a diuretic with fluticasone, but just something to keep in mind. So typically we'll see with glucocorticoids that we might be given the diuretic. Steroids can enhance or decrease the anticoagulant effects of warfarin. So obviously we need to just be looking for, if the patient's on steroid and warfarin, watch those warfarin levels, the PT-INR. Look for excessive bleeding or any indications that a clot has formed. And I've already mentioned that the glucocorticoids especially affect blood sugar levels, and so even if the patient isn't diabetic, hasn't been diagnosed diabetic, they still may experience hyperglycemia. One of the things that you as a nurse needs to know, and that patients need to be taught, is that when they're taking a steroid, they should never abruptly discontinue therapy. The adrenals are part of the renal system, and so they're very easily fooled into not doing their job. So they see there's some circulating steroids, and they say, okay, well, I don't have to be doing anything. They don't recognize that the steroid is gone and kick in immediately. So because they don't start working right away, the patient can experience then adrenal insufficiency, which means they're not producing their own steroids. Symptoms that we need to look for: fever, malaise, fatigue, weakness, dizziness, fainting, anorexia, nausea, hypertension, blah, 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 blah. Some of these you can figure out. Obviously, they're going to have muscle and joint pain because they have an fluid and electrolyte imbalance. They're going to have hypoglycemia because we've taken away the steroid and we're not utilizing the sugar appropriately. If they're retaining fluid, they might experience dyspnea, which is not very likely with adrenal insufficiency, but they will experience dizziness, faintness, weakness because of hypotension. If they don't have enough sodium and fluid, they're going to be dry, which causes a fever. They're going to be fatigued because their body's muscles and stuff just can't work appropriately. Now, I'm not sure if this is the last slide, but I think I've left out glucocorticoids. Now, glucocorticoids, remember, we are used for their anti-inflammatory or immunosuppressant properties. Typically, we see it used for, say pneumonia or something that's causing, that the inflammation is causing more of a problem than we want to see. It can be used for immunosuppression with organ transplants. It may be used along with chemotherapy. The thing that people need to understand is that they relieve symptoms. They don't cure anything. Typically, another disease might be rheumatoid arthritis. You have to think about what is the disease process. So, if you have a patient that has pneumonia, maybe they have atypical pneumonia, so they're not hospitalized, but we start them on a steroid to reduce the inflammation. Well, they're going to feel better, though their lung tissue is still insulted. They still have problems. They're going to feel better, and they may feel like they can go out and do their normal everyday activities. So we need to caution them that they need to continue to rest even though they're going to feel better. If we're giving it for, say, rheumatoid arthritis, we're giving it to reduce the inflammation of the joints. Remember, the joints are already breaking down. They've lost their synovial fluid. The bone ends are weakened and irritated and breaking down where they rub. But without that pain, what are people likely to do? Well, they're likely to go out again and think, oh, I feel good. I can do all these activities that I couldn't do yesterday, and cause more damage to their joints. Typically, the administration of the glucocorticoid is limited, 5 days or so. If it has to be chronic or long-term steroid therapy, typically we're going to use every other day therapy in order to prevent that adrenal insufficiency that we might otherwise see. So again, with steroids, assess before, during, and after electrolyte values, including that blood sugar, looking for sodium increase, potassium decrease with steroids. Fluid volume changes, obviously. So how are we going to assess that? How will we see fluid volume changes? Blood pressure, weight gain, changes in I/O ratio, level of consciousness, orientation can be symptoms of electrolyte imbalance, risk for infection is greater, especially on the glucocorticoids. In times of stress and illness, they may need a dosage change. Meticulous skin care is important for glucocorticoids, especially. All right, gonadal hormones. Obviously, this is testosterone, estrogen, progesterone. Primarily we think about estrogens for hormone replacement for menopause or in oral contraceptives. Testosterone for hypogonadism, but we can also use any of those for cancer treatment. When used for cancer treatment, we're typically using the hormone of the opposite gender. So testosterone for women, estrogens for men, because it's going to remove what the cell needs. So if I give testosterone to a woman, it suppresses the estrogen production. Well, if estrogen is what the cancer cell needs to grow, then the cancer cell is going to quit growing. I'm going to go back to estrogens for a minute. Obviously, you have to consider what is it being used for to determine the therapeutic outcome. If it's being used as a contraceptive, did contraception occur? For osteoporosis prevention, are we seeing changes in their osteoporosis? Are we experiencing less severe acne? Is the tumor growth slowed? Side effects typically include weight gain, edema, as anybody that's ever been on a oral contraceptive knows. Breast tenderness and nausea may also occur. Serious side effects are related typically to the cardiovascular system, in that estrogens can cause hypertension and thrombophlebitis. Thrombophlebitis is probably one of the biggest concerns. As anybody that's been on an oral contraceptive knows that if you smoke and take an oral contraceptive, your risk for clotting is greater. Obviously, if somebody is pregnant, then we don't want them taking an estrogen because that's going to affect fetal growth. We want to know if they have a history of cancer of the reproductive system, because if they've had ovarian cancer or uterine cancer, cervical cancer, then an estrogen would be contraindicated. If they've had previous clots, an estrogen would probably be contraindicated as well. Progestins inhibit the secretion of pituitary gonadotropins, so they prevent ovulation. But we use them to typically treat secondary amenorrhea, which is lack of menstrual cycle, secondary to some other cause. They can be used to treat breakthrough bleeding, endometriosis, and of course for contraception. Anytime you give a female hormone, weight gain, edema are possibilities. Now it's interesting to me to note that we can give it for amenorrhea and for breakthrough bleeding, and yet side effects are the same. Progestins can irritate the gallbladder, and so cholestatic jaundice can occur, headaches, and depression, mental depression. So level of consciousness kind of thing can occur as well. Androgens, primarily we're talking about the testosterone used to replace testosterone for whatever reason it might be missing. It can be used for breast cancer. Again, it's going to suppress what those cancer cells need. Gastric irritation is a common side effect. Hepatotoxicity is probably the most serious side effect. When given to children with hypogonadism, then we need to monitor the long bones, the growth of the long bones. Otherwise, they end up being very short, because one of the signals that tells the long bones to stop growing is the increased production of testosterone in males and estrogen in females. So, that's why most of us, once we hit puberty, have pretty much reached our adult height. So for women, once they start their period, they typically don't grow a lot in height. And then for men, it's harder to gauge, but deepening of the voice, growth of the hair in the pubic region, muscle mass changes are more indicative. So obviously then we would have shorter children if we give too much too soon. Okay, so I'm pretty sure I gave you everything that you need, and sorry for the delay, and have a happy weekend.